talk to you about medications alternatives to opioids, and we'll spend some time talking about that and then talk about some regulations. So I hope you can hear me well enough. So our objectives today are, at the end of the presentation, I'd like you to be able to describe the role of non-opioid pain medications in the care of patients with chronic pain. I'd like you to be able to name various categories of non-opioid pain medications. And then I'd like you at the end of the presentation to be able to identify some safe indications for these, some potential side effects, and also some contraindications to the use of these medications. I just need to start by saying that there are three types of pain generally: somatic or nociceptive pain from tissue damage, visceral pain, which can be a type of somatic pain, which is really pain that is caused by something going on in a viscera, like a heart or a gallbladder or a pelvis, often transmitted along autonomic nervous system pathways. And then neuropathic pain is pain that arises from any damage anywhere in the nervous system, be it a peripheral nerve in your finger or be it a stroke. There's three types of pain receptors: chemical, mechanical, and thermal. Most pain receptors are multimodal, which means they have all of them. So the nociceptor is how we feel pain. It's a specialized neuron that's been developed specifically to transmit pain signals to the nervous system. It's basically a transducer. It converts one form of energy to another form of energy, an electrical signal that the brain perceives. You can spacebar. Okay. All right. So let's, Chris, any way to turn off just one light, or would we have to do both of them? Okay, that'd be great. I'm getting a little glare off the screen. Can you all see me? If not, please send in a message to us. But you should be looking at slides rather than me. But at any rate, the nociceptor is that specialized neuron, and the end of the nociceptor is in the tissue, and its synapses in the spinal cord. So the longest nociceptor is the nociceptor in our big toe. So you can see in this cartoon, the nociceptor has various dendrites or branches that do allow us to perceive stimulus from our external environment. At any rate, think of this nociceptor, while we're getting the slides back, as a specialized neuron that has to convert some painful stimulus to an electrical signal that is perceived by the brain. So the nociceptor you'll see in a bit is really kind of a cool physiologic entity. On one end, there are receptors that respond to temperature, receptors that respond to chemicals that are released when tissue is damaged, like hydrogen ion, like prostaglandins, like nerve growth factor, et cetera, cytokines, chemokines. These can stimulate the nociceptor to depolarize. And you all remember from professional school that the way a nerve works is it depolarizes. The way it depolarizes by sodium going in and potassium going out of the nerve. This creates an electrochemical gradient, or an electrical signal. The electrical signal traverses the neuron, the nociceptor, and it gets to the end of the neuron, and that electrical stimulus causes lysis of bags of neurotransmitters. These neurotransmitters then spill into the synapse and stimulate the second order neuron, which goes invariably to the brain. And let me get the nociceptor back up here so we can see that. So here's the cartoon of that, and you can see on the left side of your screen the end that's in the tissue. This end can respond to various entities, and then the signal is depolarized. The nerve is depolarized. These bags of neurotransmitters lyse, and you get neurotransmitters that stimulate the second order neuron. So why am I spending so much time on this? Well, this is how our drugs work. Our anti-inflammatories, which reduce the production of prostaglandins, work here. Our anti-epileptic drugs and anesthetics work here. Our gabapentinoids work here in this calcium channel. Calcium is needed to lyse that bag. And then opioids, mu receptors are all over the place and have various functions. So once that nociceptor comes in, it synapses. I just showed you that synapse. And then the second order neuron crosses the midline and goes to the brain, carrying the signal to the brain. So this area is extraordinarily important, this area right here, because there is a lot of connections that occur here that can modify the pain signal. I lost my green arrow. So let's move on. That's some basic physiology. That's the physiology of pain in 3 slides. So what I'd like to do now is just focus on medications. We're going to talk about we sort of artificially divide these category of medicines into 2 parts, the true analgesics and the adjuvant medicines. True analgesics have as their primary indication the treatment of pain. Adjuvant medications are medications that are indicated for something else, but oh, by the way, they're pretty good for pain, like tricyclic antidepressants. Great for pain, but they're indicated for depression, like gabapentin, which is actually a seizure drug. It's an adjuvant. So let's look at these. Now, these are our major categories: primary analgesics, the anticonvulsants, the anesthetic drugs, the antidepressants, the muscle relaxers, and the topicals. And we're going to, if I'm successful, we're going to hit all of these categories this afternoon. So I must remind you that you don't see that this, you're all familiar with this WHO analgesic ladder. This is almost a half a century old. The WHO analgesic ladder was designed for cancer pain, but it stipulates, it works very well for chronic pain, and stipulates that the foundation of any pharmacologic pain regimen is non-opioid analgesics. You don't see oxycodone down here. You don't see morphine down here. The next step is the weak opioids, which used to be codeine. It's now tramadol. And the third step are all our other analgesic opioids. So let's talk about the true analgesics. True analgesics are aspirin, non-steroidals, triptans are true analgesics like sumatriptan. Steroids can be true analgesics. Most of these drugs act by inhibiting cyclooxygenase, which converts arachidonic acid to prostaglandins, which stimulate the end of the nociceptor. They are very effective for nociceptive pain. Nociceptive pain is tissue damage pain. So like surgical pain, broken bone pain, etc. Number needed to treat 2 to 4 patients with a non-steroidal to get a 50% reduction in pain. To put that in perspective, a statin, you need to treat about 100 to 150 patients with a statin to prevent 1 major MI. So these are very effective drugs. You all are familiar with the adverse effects: GI ulceration, kidney problems, specifically with our diabetic patients. Be careful whether they have kidney disease or not. Elderly patients, cardiac. Now, if all of you would open your prescribing information to any non-steroidal, you'll now see a big black box warning that warns us to be careful, because these drugs, all of them, increase the risk of heart attack and stroke. And this risk starts at 2 weeks of therapy. It used to be taught that it was just the COX-2s, the selectives. It's all of them. All of them now have this warning. So contraindications: these medicines are often used when they shouldn't be used. They shouldn't be used in patients with active peptic ulcer disease. They shouldn't be used in patients that have bleeding tendency. That means patients on anticoagulants should not be using these drugs. They should not be used in patients with renal disease. You need to be cautious during the 3rd trimester of pregnancy. And with celecoxib, Celebrex, you need to be careful. They have a mild interaction with sulfa-allergic patients. So some pearls. I always check metabolic parameters periodically. I check the CBC, LFTs, and the metabolic profile to be sure I'm not inflaming the liver, causing anemia, or causing renal damage. I always prescribe these with a PPI or an H2 blocker. Always, always, always. Because there's reasonable data that if you use these long term with a PPI or an H2 blocker, like Pepcid or ranitidine, that you will reduce the risk of bleeding. Not eliminate, reduce. Use these drugs with caution in the elderly. I don't like to use these in the elderly, and I try to avoid it if possible. If I use them in the elderly, I'm extraordinarily cautious when I use them. Elderly are much more susceptible to side effects. Remember, if you use acetaminophen, to keep that dose below 3 grams per day. Used to be 4 grams, it's now 3 grams. And that is in a healthy person. In an elderly person or a person with malnutrition, for whatever reason, you want to use these doses at extraordinarily low levels. I don't exceed 2 grams. Be cautious if you use these in alcoholic patients. So let's talk. That was a whirlwind tour through the true analgesics. I haven't talked about triptans and I haven't talked about steroids, but they're also true analgesics. Let's talk about our next major group, which are anticonvulsants. Now, generally, anticonvulsants are used for neuropathic pain. They have very little use in nociceptive pain, so neuropathic pain generally. Prototypical agents are gabapentin, pregabalin, carbamazepine, valproic acid, and topiramate. The latter two drugs are FDA approved for migraine prophylaxis. Carbamazepine is approved for atypical facial pain syndromes and tricutis. And gabapentin and pregabalin variously have indications for diabetic neuropathy and peripheral and postherpetic neuralgia. These act by inhibiting the influx of calcium into the neuron that allows those neurotransmitter bags to be lysed. They're indicated, gabapentin and pregabalin, postherpetic neuralgia, diabetic peripheral neuropathy, fibromyalgia for pregabalin, and very effective. Valproic acid, topiramate, migraine, carbamazepine, as I have said. Let's talk about the ones we use the most. Gabapentin, I told you how that worked. I showed you on the cartoon how it inhibits calcium influx. By doing that, by inhibiting the calcium influx and preventing lysis of those bags of neurotransmitters, you don't get release of these very active neurotransmitters into the synapse, like glutamate, norepinephrine, substance P, dopamine, serotonin. All these things get reduced in the synapse when you use these drugs. Uses, as I mentioned, we use gabapentinoids for fibromyalgia all the time. It is off-label. Diabetic for gabapentin, diabetic peripheral neuropathy off-label, postherpetic neuralgia, it is approved for postherpetic neuralgia. So I just tell you that just to let you know you really need to remind patients when you're using a medication off-label. Doesn't mean you can't use it, but it means that it is not FDA approved. Although we all use it, of course. Gabapentin, the trick to gabapentin is starting it low and going slow. So I start elderly patients at 100 at nighttime, and I gradually increase the dose by 100 milligram increments. If they can tolerate it in the daytime, I dose TID. If they can only tolerate it at nighttime, I dose it at night. With people that are middle-aged or young, I treat them with 300 at bedtime, gradually increase the dose. If you don't start gradually, patients are going to get side effects and they're going to stop the drug. They're going to get scared and stop the drug, and they may lose a potentially useful drug. This drug, like any of our anticonvulsants, like any of our antidepressants, do not stop them abruptly. Taper them if you can, if at all possible when you stop, because you can cause withdrawal symptoms. Biggest side effects, you know the side effects of gabapentin, you use it all the time. Somnolence. Patients tell you that they're tired from it. That's why we sort of ramp up slowly. Patients complain of edema. Patients complain of weight gain. Some of the unusual side effects are effects on the bone marrow. You can actually drop the blood count with these. So periodically check the blood count. Now it has as every drug that I'm going to talk about in the seizure category and the antidepressant category, every one of them has a warning about increased suicidal thinking. So be very cautious when you start these drugs in patients with significant depression. They will cause increased suicidal thinking. I've had it happen with my patients. For gabapentin, renal failure is a relative contraindication. If you use this in dialysis patients, please use it with a nephrologist holding your hand, because you have to dramatically reduce the dose. Look at your prescribing information for those patients that have reduced renal function, because you have to adjust the dose. It's all in the prescribing information. Pregabalin. Pregabalin is a gabapentinoid, works just like gabapentin. It is, however, a controlled substance. It's C5. It's a C5. So that's why you have more difficulty prescribing this than gabapentin. In initial testing, it was shown to cause euphoria, and there are increasing reports of patients abusing this for its euphoric effect. It's approved for postherpetic neuralgia, diabetic peripheral neuropathy, fibromyalgia, and spinal neuropathic pain, all approved indications. The reason we use lower doses is because it's better absorbed. Seems to have decreased somnolence compared to gabapentin. And importantly, with gabapentin and pregabalin is it improves non-REM sleep. This is critically important because pain patients have very poor sleep architecture because of the nature of their pain. So this will actually improve sleep architecture. I start at 50 TID, 50 BID TID. I work my way up. I rarely go higher than 450 to 600. That's my usual dose is tops at 450. Again, watch out for the renal function. You've got to reduce it. Side effects, somnolence, dysphoria, euphoria. And there's a little bit of a risk of angioedema. Just like with your ACE inhibitors, you can cause angioedema with this. So I always warn patients about swollen tongue, swollen throat, etc., that they need to advise me. And again, never stop this abruptly. Topiramate, very good drug. Used for neuropathic pain, but our go-to use for this is migraine prophylaxis. Pretty darn effective. FDA approved for that. We also use it for cluster headache. We can use it in all manner of other types of neuropathic pain, diabetic peripheral neuropathy, for example, postherpetic neuralgia, for example. I generally start low, 25 milligrams BID. I work my way up to 100 QD. A couple things you've got to know about this drug is it does cause a mild acidosis. Because of that, it can increase the risk of kidney stones. So you should not use this drug in someone who has kidney stones. You should remind patients about the problem that can cause kidney stones. It can cause increased intraocular pressure. So if patients this is a newly identified side effect. If patients complain to you about their vision, you need to take that seriously and consider taking them off the drug. Again, reduce it with renal insufficiency, and I remind you, black box warning, increased suicidal thinking with all of these drugs. Not many of you, I imagine, use the carbamazepine or oxcarbazepine. These are somewhat specialized drugs for neuropathic pain. As mentioned, we do use them in tic douloureux, trigeminal neuralgia, and it is approved. We can also use these in neuropathic pain. It's third line for some neuropathic pain states. Now, one thing I want to impress upon you about this drug if you use it, if you have a patient of Asian descent, you must check this particular allele that I have on your screen, the HLA-B1502. Patients that have this allele are more prone to developing toxic epidermal necrolysis and Stevens-Johnson's, which, as you know, is an awful, potentially fatal illness. So caution with your Asian patients when you prescribe this medication. On one of these talks, one of our individuals asked about Native American patients because of the possibility of some Asian blood many millennia ago. The answer to that is there does not seem to be an increased risk in Native American patients that don't have direct Asian blood. Valproic acid, migraine, approved for migraine prophylaxis, good medicine, a little bit tougher to use because of side effects. We'll get into that in a sec. Again, any kind of neuropathic pain, but this is particularly indicated for migraine prophylaxis. This drug, in addition to carbamazepine, can cause fluid and electrolyte problems. So, kind of keep an eye on those electrolytes when you use these drugs. Now, one thing I always tell folks about valproic acid, if you use it, be very careful to monitor the CBC as well. CBC and LFTs. This, of all the anticonvulsants, this particular one seems to be a little bit rougher on the liver, a little bit rougher on the bone marrow. This will cause an almost dose-dependent drop in the platelets that you will see. That does not necessarily mean that you have to stop it, but you should monitor it very closely. So those are antidepressants, gabapentinoids, pregabalin, gabapentin, valproic acid, topiramate, carbamazepine. Let's talk about antidepressants now. Again, good medicines for pain. Our prototypical agents are the tricyclics and also our SNRIs, our non-selective group of serotonin reuptake inhibitors. There's 2 of them in common uses, venlafaxine and duloxetine. There's another one that most of us don't use because it's so expensive, called Savella, milnacalcipran. We don't use that primarily, at least at my institution, because it's not on any of the formularies, but it's in this category. How do they work? Well, there are descending pathways from the brainstem that modulate pain at the level of the spinal cord. We think that they work by increasing the flow of norepinephrine through these neurons and causing pain inhibition at the level of that synapse that I showed you in the dorsal horn of the spinal cord. So that's how we think they work. And we think that the reason they work is their norepinephrine reuptake inhibition, because the SSRIs really don't have good pain properties. So let's talk about TCAs. I grew up with these. I did my residency in the 80s, in the late 80s, and that's all we had, tricyclics. So I got very facile with the use of these, and I love these drugs for neuropathic pain. They're better for peripheral rather than central. We use them for all manner of neuropathic pain. It's my go-to drug after gabapentinoids for neuropathic pain. Specifically diabetic peripheral neuropathy, postherpetic neuralgia, peripheral neuropathy of unclear etiology. Of course, I use it very frequently in migraine prophylaxis. It can be used a lot in other headache syndromes as well. And when I say tricyclics, I mean amitriptyline, doxepin, nortriptyline, imipramine, desipramine, that whole family. There's a bunch of others, but those are the ones generally that I use. Number needed to treat, 2 to 4 patients for a 50% reduction in pain. That's a Cochrane review. The problem is patients have trouble tolerating these. So even though they work well, patients have trouble tolerating these, and you often have to start them very slow and coach the patients and hold their hand as you increase the dose. I generally use the sedating medications for those that can't sleep. The sedating medications are doxepin and amitriptyline or triptyline. For those that are too sleepy and need a little activation, I tend to use desipramine, occasionally protriptyline. Remember that these are have to be started slowly. As I mentioned, for pain, I rarely go higher than 75 to 100. For depression and pain, you have to get into the hundreds. Side effects, you all know the side effects of these drugs. Sedation, orthostatic hypotension, anticholinergic effects. These are the common things that everybody feels. The side effect that we fear the most is the cardiotoxicity. And we need to be very, very careful about cardiotoxicity. And we'll talk about that in a second. Remember, increased suicidal thinking with these drugs. So just to remind you, tricyclics, the thing we fear the most is their cardiac side effects. These are type 1 antiarrhythmics. For those of you that are old enough to remember procainamide and quinidine, that's the type of category that they are in. They prolong all aspect of the cardiac cycle, the electrical cardiac cycle, the PR, the QRS, but most importantly, the QTC interval. And therein lies the complications. When the QTC interval is prolonged above 450 milliseconds, you increase your risk of serious ventricular dysrhythmia called torsade. It's probably safe they're probably safe up to 100 milligrams, although I generally check a cardiogram on everybody at any age before I start this drug and as I'm increasing the dose. The formal recommendations are above 40, but I check everybody. Now, just as a sidebar, the way you get into trouble with tricyclics as a general internist or family medicine doc is you use these drugs and then you forget that other drugs interact. So, for example, if you start someone on clarithromycin for H. pylori and they're on a tricyclic, you're going to send the QTC through the roof. If you start someone on an antifungal, you will affect the QTC. So I generally always remind patients to please check with a pharmacist if someone else prescribes a medicine when I'm prescribing a tricyclic. Let's move to venlafaxine. Venlafaxine is an antidepressant, a mixed non-selective agent, as we discussed. Probably need to get this drug up to 100 milligrams to have a pain effect. It's effective in all manner of neuropathic pains. We use them commonly in diabetic peripheral neuropathy, fibromyalgia. We use it in headaches. Number needed to treat is 3 to 1, as opposed to the tricyclics for pain, which is a little bit lower. Remember that pain usage is off-label, just like with tricyclics. Pain usage is off-label, although we commonly do it. The biggest problem I run in with venlafaxine in my population is hypertension. A lot of my patients have hypertension, so if you're going to start this, the blood pressure must be controlled, and you got to watch it for a little bit more carefully. And so when you're ramping up the dose of this drug, be careful to keep an eye on the blood pressure. This has serotonin effects, so if you use it with other serotonin drugs, you run the risk of having serotonin syndrome, which is an excess of serotonin, often manifesting itself as a hyperadrenergic state and a hypermotor state. Again, increased suicidal thinking when you use this, even though we're using it for pain. Duloxetine, another non-selective, we use a lot of this. Thankfully, it's now off patent, so we can get it a lot easier. It does have indication for a lot of pain indications. This is one of our antidepressants that does have FDA pain indications. So pain indication for peripheral neuropathy, diabetic peripheral neuropathy, fibromyalgia, chronic musculoskeletal pain. Again, unfortunately, the number needed to treat a little bit higher for this category of drugs than the other. For me, as a pain doc, I will probably use 60 to 90 and stop at 90. For someone like Dr. Chowdhury, who's a psychiatrist, I'm sure he probably goes higher on this dose when using it for depression and pain. Duloxetine, the side effects, again, you keep seeing me put up increased suicidal thinking. The most common reason for me stopping this drug is patients complain of they just can't do it because of nausea. So I try various ways to with food, without food. I try all sorts of tricks to see if I can get them to tolerate it. One of the peculiar side effects that's common to all SSRIs, but this one in particular, is it can cause liver inflammation. And I have had this happen, not uncommonly. So be careful to check the LFTs periodically with this drug. And I would caution you not to use it with patients with active liver disease. Also be cautious to adjust it when a patient has renal insufficiency. Again, be careful with serotonin syndrome. Most of these antidepressants have this quality, and we'll talk a little bit about tramadol. The common mistake that I see is patients are on a standard SSRI and they have pain, and clinicians forget that these are also serotonin increasing drugs, and they prescribe, in addition to the SSRI, they prescribe duloxetine, and now they're getting 2 serotonin drugs, which increases the risk of serotonin syndrome. So that's a whirlwind tour through the antidepressants. We've talked about them in very broad strokes. We're going to talk about tramadol. So you say, well, wait a second, this is a non-opioid presentation. Why is he talking about tramadol? Well, you're right. Tramadol is an opioid. It's a very weak opioid. It's categorized as a C4. In most states, it's a controlled substance, and it has to be handled according to most boards of medicine and pharmacy as any other controlled substance. It has a very low affinity for the opioid, for the mu receptor, perhaps 1/100th of that of oxycodone. But the real way that this drug probably works is not as a mu receptor agonist. It probably acts more like duloxetine, more like venlafaxine, in that it increases norepinephrine in the brainstem, thereby increasing sympathetic anti-nociceptive stimulus to the spinal cord. FDA approved for moderate to severe pain. So my go-to use of tramadol is the elderly patient that's got osteoarthritic pain. You certainly don't want to give them a full mu receptor agonist, a full opioid, and you certainly don't want to give this elderly, frail patient non-steroidals. So what I'll do is I'll give them a little bit of this, a little bit of tramadol and start them off on that. Now, I hasten to add, this is not American Rheumatologic Association guidelines. This is what we do in pain practice, but it's not the guidelines according to the American Rheumatologic Association, which says start with Tylenol and other non-steroidals. Of course, we always start with acetaminophen. Dosage 50 to 400. I find I rarely go above 300. I just don't find much more of an effect after 300. Number needed to treat 6 patients. Not like some of our other drugs. You got to treat 6 patients for 1 patient to benefit. Adverse effects, they share opioid adverse effects, somnolence, serotonin syndrome with other drugs. These can be habituating and they can be abused. That's why they're C4. So patients can abuse this just like any other opioid. Side effects, other side effects, nausea, vomiting, dizziness, constipation, somnolence. Now, very interestingly, this, even though this can cause somnolence, it has a neuroexcitatory property and can increase the risk of seizures. So, and I've done this with patients. I've given a patient a seizure with tramadol, and when you speak to neurologists, they will say that this is now a very common reason to have patients presenting with new onset seizures. Beware of interactions with other drugs, MAO inhibitor type drugs like linezolid, which many of you use for staff for MRSA in the hospital. Extensively metabolized by P450 enzyme, so a lot of interactions. Watch out for patients with cirrhosis. Be very cautious if you use it at all, and be very cautious in patients with renal insufficiency. So we've got about 10 minutes left. Let's go through the last categories. Muscle relaxants we divide artificially into 2 categories. The true anti-spasticity drugs that actually reduce muscle tone, and then all the others that the mechanism is not entirely clear, but they seem to help spasticity. So most of these drugs act by reducing tone of the muscle, some at the motor endpoint. Baclofen, tizanidine, diazepam, dantrolene, and Botox. These are our true anti-spasticity drugs. So let's go through these. Baclofen actually causes the spinal neuron in that dorsal horn. It causes, by stimulating that spinal neuron, it causes inhibition of muscle tone. So this drug is used for central spastic conditions like pain resulting from multiple sclerosis, post-stroke pain, spinal cord injury. Very, very effective. Again, it scares people away if you start them at full dose. So start them at 5 to 10 milligrams. Build the dose up slowly. Remember, it's got a withdrawal syndrome. So if you have patients on this drug chronically and stop suddenly, they can actually get a withdrawal syndrome. This is so serious that when it's put in pumps, that patients can have life-threatening events if their intrathecal pumps start malfunctioning. Muscle relaxants, benzodiazepines are also GABA mimetic. The problem is that to use a benzo to reduce muscle spasm, you have to use a relatively large amount. So the small amounts of benzos we use probably do not cause muscle anti-spastic effect on the muscle. And of course, we don't like to use them in frail elderly patients, and we prefer not to use these with opioids because there's very significant statistically increased risk of accidental overdose, so we try to discourage that combination. Tizanidine, I use a lot of this. This works as a central alpha mimetic. What that means is it tells the sympathetic centers to reduce their output peripherally. Reduced sympathetic output to the muscle results in relaxation. I generally start it very low at 4 milligrams. The maximum dose is 36, but I got to tell you, I've never gotten anybody up that high. It's too much of a hypotensive drug to get up that high. And that's indeed, when you use this, think that you're using clonidine, basically. You're using something like clonidine, which is an antihypertensive. They're pharmacologically almost identical. So titrate it slowly, watch the blood pressure. If folks get hypotensive with this, they'll stay hypotensive for days. It takes days to reverse this, and sometimes folks have to be hospitalized. So be very careful. This, like clonidine, can affect the SA node, so watch the heart rhythm, watch the electrocardiogram, and it has a peculiarity that clonidine doesn't have, that it can inflame the liver. So watch the LFTs on this. So those are the anti-spasticity drugs. I didn't talk about dantrolene. I would encourage you not to use dantrolene, potentially very liver toxic. And Botox is also an anti-spasticity drug that we use commonly in migraine headaches. Antispasmodic drugs are that other category of muscle relaxants that, oh, by the way, they seem to help muscle spasm, but we're not terribly sure how they work. Generally, most of these are indicated for short-term use. Let's go through a few. The prototypical muscle relaxant is cyclobenzaprine. Of course, there are other categories that you all know and love: Robaxin, methocarbamol, orphenadrine, Norflex, methoxylone, scalexin. These are all used for muscle spasm, often after an injury. They all seem to be effective, but again, they're only indicated for short-term use. Cyclobenzaprine is interesting. It is very effective, but it basically, when you prescribe cyclobenzaprine, I'd like you to think of this as a tricyclic, as using a tricyclic. Similar chemically, similar mechanism of action, and almost identical side effects. So cyclobenzaprine, 10, maximum dose 30 per day, a lot of sedation. Be very careful if you're using this with other QTC drugs. Not indicated for long-term use, although I have to tell you, I've got plenty of patients on it long-term. Finally, in the muscle relaxant category, Soma, carisoprodol. Don't use this drug. This really, in the opinion of most of us in the pain community, this drug should not be used for pain, and we strongly discourage it. It has an indication for muscle spasm, but we strongly encourage you not to use this. This is potentially disastrous when used with opioids, and it is very highly addictive and potentially dangerous. By the way, this has street value. This is used on the street. So in the last 3 minutes, I'm going to quickly go through topicals. So topicals are medications that we apply to the skin, obviously. Topicals are different than transdermals. Transdermals are drugs that are designed to be applied to the skin and have a systemic effect. Topicals are designed to have a local effect. Can they have some systemic absorption? Of course. Of course they can. So let's review some of the topicals. I use a lot of topical NSAIDs. I love these for local, arthritic conditions like sore shoulders, sore knees, back. I'll occasionally use this in back. Diclofenac, ketoprofen, naproxen. We use those. They come in various concentrations. I do know that there's several formulations of diclofenac that are now generic. Sometimes it's hard to get this, but pretty darn effective. Good data. Lidocaine, another topical, 5%. The ointment, 5% ointment is usually the one that the insurance companies will approve. Comes in many dosage forms. I tend to use this with patients with syndromes like postherpetic neuralgia, for which it's approved. I use it for diabetic peripheral neuropathy. I actually use it for back pain, believe it or not, because there's an element of neuropathic pain called allodynia in most patients with back pain. Capsaicin is really very, very interesting stuff. This is what makes chilies hot. We are the chili capital of the world, I want you to know, here in New Mexico, if you don't know that already. Capsaicin comes in various concentrations, and we're not sure, we think it acts by exhausting substance P in the nociceptor. Because of that, capsaicin really needs to be used continuously, not PRN, because its effectiveness is predicated upon reducing the substance P in the nociceptor. The mistake that's always made is patients use this PRN and says, oh, it makes my skin hot, but it doesn't work. If you use it for painful conditions, consider trying lidocaine before you apply it, specifically for the peripheral neuropathies. the direct application of capsaicin can be really, really uncomfortable. There's a product, and I have no financial interest in this or of Salonpas Hot, but this I'm using more and more in patients because it's a very affordable, easy to use way to have capsaicin applied, and I use this a lot in back pain. In very severe conditions, you can use the 8%, which you apply for 20 seconds for long-lasting relief of pain syndromes. So there are many other topicals that are out there, especially compounded topicals. I didn't go through them. Many of your pharmacies will do this for you. I hasten to add that some of the more complicated mixtures of these agents don't have a lot of scientific data behind them. So let's just summarize. We've talked about basic pain physiology. We've talked about true anti-pain agents, which are nonsteroidals, aspirin, APAP, steroids, triptans. We've talked about anticonvulsants, indicated for neuropathic pain primarily, gabapentin, pregabalin, the other anticonvulsants. We've talked about antidepressants, spent a good bit of time on tricyclics, but also mentioned venlafaxine, duloxetine, and then we've talked about, of course, tramadol, our muscle relaxers, and our topical agents. So I'm going to go ahead and stop.